Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I'm the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which may prove handy in your line of duty. So I welcome you to part 83 of our pharmacotherapy MCQ series, which measures in basic oncology. Our first question reads, Mr. H.A.W., 47-year-old male patient, regularly brings his mother, who happens to be a cancer patient, to your oncology clinic for systemic treatment for papillary cell renal cell carcinoma. He is a married accountant who smokes 1.5 packs of cigarettes on a daily basis and is a social drinker of alcohol. Mr. H.A.W. has a past medical history of hyperlipidemia, GERD, type 2 diabetes mellitus, chronic kidney disease, and he seeks to reduce his risk of renal cell carcinoma in future. So my question to you is, which of the risk factors listed below should he urgently manage in order to prevent future renal cell carcinoma? Is it the chronic kidney disease? Should it be smoking habit? Or would it be the hyperlipidemia or type 2 diabetes mellitus? I'll give you 10 seconds to choose the correct answer. Smoking it is. Now, smoking and obesity are established risk factors for renal cell carcinoma. Now, current smokers in literature have a 60% higher risk of RCC, and there is a dose-response relationship to the risk of renal cell carcinoma. Now, hypertension is also associated with an increased risk of RCC. And then I would like to add that CKD by itself isn't a significant risk factor for renal cell carcinoma, although acquired cystic kidney disease associated with end-stage renal disease is a significant risk factor for RCC. I would also like to add that hyperlipidemia and type 2 diabetes mellitus have been shown to have some positive associations with RCC, but they aren't as significant as smoking cessation. So let's move to the next question, please. And it reads, which of the sets of risk factors listed below apply specifically to breast cancer? Is it first-degree relative with breast cancer, previous exposure to chest wall irradiation, and early menopause? Or is it early menstruation, late onset menopause, and older age at first live childbirth? Or is it female gender, prolonged hormone replacement therapy, and absence of what we call the BRCA1 gene? Or is it older age, a history of breast cancer with grandmother, diagnosed at the age of 67 years, and benign proliferative breast cancer? I'll give you 10 seconds to choose the correct answer. So the correct answer is B, early menstruation, late onset of menopause, and older age at first live childbirth. Now, for answer C to be correct, there must be the presence of the BRCA1 gene, not the absence. And for answer D to be correct, there should be a history of breast cancer in a first degree relative or a family history at a younger age, that is below 45 years. Now, for answer A to be correct, it should have been late onset menopause, not early onset menopause. And longer a woman is exposed to estrogen, the higher the risk of breast cancer. It's quoted in literature. And the later or the greater the woman's age is during the first live childbirth, that is above 30 years of age, the higher the risk of breast cancer. So all those many words justify why B is our correct answer. Let's move to the next question, please. And the question reads, your medical oncologist initiates two 48-year-old female patients with two different types of cancer on doxorubicin and cyclophosphamide for a breast cancer patient, and doxorubicin, cyclophosphamide, vincristine and prednisone for a non-Hodgkin's lymphoma patient. So my question to you is, in which case are we more likely to witness acute and delayed nausea and emesis, assuming they receive similar antiemetic regimen? Is it true that both regimens would have a similar risk? Or is it true that the AC regimen is more emetogenic than the SHOP? Or is it true that SHOP is more emetogenic than the AC regimen? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. The AC regimen is more emetogenic than SHOP. Now remember, the breast cancer patient receiving an anthracycline containing regimen is more likely to experience nausea and emesis than the other patient. Remember, breast cancer patients possess a higher level of anxiety that will exacerbate their nausea. Now, even though SHOP has another chemotherapeutic agent, which is vincristine, its emetogenicity is probably lower since it also contains prednisone, a steroid, for 5 days. Now, this prednisone will diminish nausea and vomiting effects from the chemotherapy drugs in that regimen. I would just like to add that vincristine is minimally emetogenic agent. So all those many words justify why B is our correct answer. Let's move to the next slide, please. And it reads, Mr. AFP, a 66-year-old smoker, is rushed to your accident at emergency following a motor vehicle accident. The emergency medicine consultant on duty orders an abdominal CT which reveals a 5 centimeter incidental mass on his left kidney, and then further studies confirm no other organ involvement. There is no apparent gross hematuria. So my question to you is, which of the treatment options listed below would be the best one for Mr. AFP now? Would it be radical nephrectomy, then the administration of sunitinib? Would it be partial nephrectomy followed by surveillance? Would it be partial nephrectomy followed by IL-2 therapy? Or would it be a partial nephrectomy followed by sorafenib? I'll give you 10 seconds to choose the correct answer. So B would be the best choice. Now remember, AFP has a stage 1 renal cell carcinoma. Now the standard care would be to undergo partial nephrectomy if feasible, or radical nephrectomy. Now since his tumor is confined to the kidney, the optimal treatment for him would be a partial nephrectomy. And there is no established role for adjunctive therapy for nephrectomy in patients with stages 1 to 3 of the renal cell carcinoma. And I would just like to add that randomized trials have shown no delay in time to relapse or improvement in survival with the adjuvant interferon alpha or even the IL-2 or the cytokine combinations versus observation alone. So I would also like to add that I read somewhere a multi-center phase 3 study showed no survival benefit with the use of sunitinib, which is marketed as Sutent, or sorafenib, which is marketed as Nexavar, versus placebo as adjuvant therapy after nephrectomy. And observation, in my opinion, is the standard of care after nephrectomy. And just remember that RCC can be associated with paraneoplastic syndromes that lead to what we call the Stauffer syndrome. They can also cause hypercalcemia and even increased erythrocytes. Just as a by the way, let's move to the next question. And it reads, which of the agents listed below is associated with the risk evaluation and mitigation strategies, what we call the REMS program, due to QT prolongation and even incidences of sudden death? Is it idelalisib, or is it venetoclax, or is it vandetanib, or is it lenalidomide? I'll give you 10 seconds to choose the correct answer. So vandetanib it is. Now vandetanib has an established REMS program for these serious side effects that have been quoted in that question. Now just like to add that lenalidomide has a REMS program due to embryo-fetal toxicity causing birth defects or embryo-fetal death. Now venetoclax isn't associated with any REMS program at all, and idelalisib has a REMS program due to fatal or even serious hepatotoxicity. It can cause severe diarrhea, colitis, pneumonitis, infections, and even intestinal perforation. Now just like to add that vandetanib, which is marketed as Caprelsa, can prolong the QT interval, and it can even cause torsade de pointes, and sudden death can occur in patients who are receiving the same. Now because of this risk, Caprelsa is only available through what we call the Caprelsa REMS program, and under this program only certified prescribers can prescribe this drug Caprelsa. And I would just like to add that Caprelsa is contraindicated in patients with congenital long QT syndrome. Do not administer it ever in such patients. Let's move to the next question, please. And the next question reads, Mr. JIT, a 57-year-old male small cell lung cancer patient, is being treated by your medical oncology team using cisplatin at a dose of 75 milligrams per meter squared on day 1 and etoposide at a dose of 100 milligrams per meter squared on days 1 to 3. And you established that after cycle 1 he complained to the medical oncologist of vomiting, and there were 3 episodes starting 48 hours after chemotherapy. So my question to you is, what type of emesis is this, and which of the two agents is responsible for this outcome? Is it acute emesis due to cisplatin administration? Is it a delayed emesis from cisplatin? Or is it an acute emesis due to etoposide? Or is it a delayed emesis due to etoposide? I'll give you 10 seconds to choose the correct answer. So this is a clear case of delayed emesis from cisplatin administration. Now remember, cisplatin is the classic agent known to cause delayed nausea and vomiting. Remember, delayed nausea and vomiting occurs 24 hours after receiving cisplatin. And I would just like to add that etoposide is unlikely to produce acute nausea and vomiting, since it's considered a low risk agent when used alone. Let's move to the next slide, please. And the next question reads, Mr. WOC, a 64-year-old male patient, is diagnosed with an adenocarcinoma of the lungs by your medical oncologist. Today at presentation, he has hemoptysis. His first cycle of cisplatin and paclitaxel is due today. So my question to you is, which of the antiemetics listed below would be the most appropriate for Mr. WOC to receive prior to his first cycle of chemotherapy? Would it be oral ondansetron at a dose of 16 milligrams alongside prochlorperazine at a dose of 10 milligrams orally? Or would it be 125 milligrams of aprepitant orally plus 16 milligrams of ondansetron orally plus 16 milligrams of dexamethasone orally? Or would it be 125 milligrams of aprepitant orally plus 20 milligrams of metoclopramide orally plus 16 milligrams of dexamethasone orally? Or would it be 16 milligrams of ondansetron orally plus 20 milligrams of metoclopramide orally? I'll give you 10 seconds to choose the correct answer. So I would settle for 125 milligrams of aprepitant, 16 milligrams of ondansetron, and 16 milligrams of dexamethasone, all administered orally. Remember, WOC is at a high risk, that is above 90% for emesis, and according to the NCCN guidelines, any of the following 3 drug antiemetic regimens should be given prior to highly emetogenic chemotherapy on day 1. So you can either choose an NK1 antagonist, which may be aprepitant, either orally or IV, a single dose, or you could settle for fosaprepitant IV, a single dose, or even netupitant co-formulated with polanosetron orally, a single dose, or even polanosetron co-administered with the fosnetupitant, but IV this time as a single dose. Or you can even settle for rolapitant, but that would have to be an oral dose as a single one, and any choice from that group would be co-administered with a 5-HT3 antagonist such as lolanesetron as a single oral dose, or granisetron either via sub-Q, oral or IV route as a single dose, or even transdermally. Or you would settle for ondansetron either orally or IV as a single dose, and you could also settle for palonosetron as a single IV dose. And you could also add to that dexamethasone either orally or IV. Now a second option would be an oral dose of olanzapine together with palonosetron alongside dexamethasone, where the palonosetron is a single IV dose, the olanzapine is a single oral dose, and the dexamethasone can be a single oral or IV dose. A third optional modality would be 10 milligrams of olanzapine orally and an NK1 antagonist. So you choose one from either oral or IV aprepitant, or you would settle for fosaprepitant IV, or you would settle for netipitant co-formulated with palonosetron as a single oral dose, or you'd even settle for fosnetipitant co-formulated with palonosetron as IV as a single dose. You'd even settle for rolapitant, it's a difficult one to pronounce, and that could be co-administered with a 5-HT3 antagonist, which could either be dolasetron as a single oral dose, or granisetron, which can be sub-Q oral or IV as a single dose, or even the transdermal form. And you can also settle for ondansetron oral or IV as a single dose, or even palonosetron as an IV dose, and that should be co-administered with either oral or IV dexamethasone as a single dose. Now I would just like to add that if aprepitant 125 milligrams is administered orally on day 1, it should be followed by 80 milligrams on day 2 and 3. And if the combination product of netipitant and palonosetron or fosnetipitant and palonosetron is used, then no further 5-HT3 antagonist is needed. That would be therapeutic duplication, so be cautious. And I would like to add that if dexamethasone 12 milligrams either orally or IV is used as the first dose on day 1, that is, then it should be followed by an 8 milligram dose from day 2 to day 4. And if olanzapine 10 milligrams oral is used as the first dose on day 1, it should be followed by 10 milligrams orally daily on days 2, 3 and 4. I would just like to emphasize that metoclopramide hasn't been studied in combination with aprepitant, and that makes alternative C wrong. And then concomitant administration of metoclopramide, prochlorperazine, promethazine, or even haloperidol should be used with caution, since excessive dopamine blockade can increase the risks of extrapyramidal symptoms, and that would complicate issues for us. So those many words justify why B is the best answer in this particular clinical scenario. Let's move to the next question, and it reads: for which of the agents listed below should a dose adjustment be done in a case of severe hepatic impairment? Is it bleomycin, cyclophosphamide, vinorelbine, or oxaliplatin? I'll give you 10 seconds to choose the correct answer. So vinorelbine it is. It requires a dose adjustment. I'd just like to remind you that vinorelbine, marketed as navelbine, is a vinca alkaloid antineoplastic agent which is commonly used for the treatment of non-small cell lung cancer, and it should be used with caution and at lower doses in patients with known hepatic insufficiency. I'd just like to emphasize that there is a dose adjustment based on the serum bilirubin level, and in literature they say if the bilirubin level is less than 2, then we should administer 100% of the daily dose, and if it lies between 2.1 to 3, then we should give 50% of the dose, and if it exceeds 3, then we should only give 25% of the dose. Now, failure to do so can further increase the risk of hematological, neurological toxicities, which are already associated with this product, vinorelbine. So let's move to the next question, please. And it reads, Mr. ALG, a 55-year-old male patient, has failed tyrosine kinase inhibitor-based treatment by your oncology team on multiple attempts. This gentleman has received a conditioning regimen and has also completed allogeneic matched unrelated donor hematopoietic stem cell transplant. And the oncology team is considering to initiate tacrolimus plus methotrexate for graft versus host disease prophylaxis. So my question to you is, which of the conditions listed below would be the most concerning in Mr. ALG's case with regard to initiating methotrexate? Would it be concurrent use of fluconazole prophylaxis? Would it be grade 1 mucositis on physical examination? Would it be presence of a pleural effusion on the CT of the chest? Or would it be an estimated creatinine clearance of 50 ml per minute? I'll give you 10 seconds to choose the correct answer. The presence of a pleural effusion on the CT of the chest would be most worrisome. Remember, methotrexate is a hydrophilic agent with a volume of distribution that approximates that of total body water, and it can therefore readily diffuse into third spaces such as a pleural effusion, which can lead to a prolonged terminal half-life of methotrexate and a significant increased risk of toxicity, and thus should be avoided due to the presence of a pleural effusion. Remember, methotrexate can cause or worsen mucositis, but at this point mucositis is mild and manageable. Remember that. And I would just like to add that methotrexate is renally cleared, and abnormal renal function can result in increased risk of methotrexate accumulation or concentration in the body. Remember, Mr. ALG has a mild abnormal renal function, and methotrexate could be initiated with a dose adjustment, and that should be accompanied by close monitoring. Just like to add that the methotrexate isn't metabolized through the CYP450 system, and there isn't a drug-drug interaction with fluconazole at all, and that makes answer A wrong. So those many words justify why C would be our best answer in this particular case. Let's move to the next question, please. And it reads, which of the tyrosine kinase inhibitors listed below prevents the formation of oncogene EML4-ALK? Is it sorafenib, vandetanib, crizotinib, or dasatinib? I'll give you 10 seconds to choose the correct answer. So Zalcori or crizotinib is the best answer in this particular case. Now, this crizotinib is a TKI for locally advanced or metastatic non-small cell lung cancer that possesses an ALK, what we call an antineoplastic lymphoma kinase mutation. Now, by blocking the phosphorylation of ALK, this will not allow the fusion protein to be developed and will therefore allow for apoptosis to occur. Let's move to the next question, please. And it reads, your medical oncologist initiates therapy of renal cell carcinoma in a female patient by the name NTP, who happens to be 68 years old, and he uses sorafenib at a dose of 400 milligrams orally twice a day. Now, 14 days into her treatment, this lady begins to complain of swelling and tingling, and NTP also has an erythema in both her hands and feet, and she confirms to the oncologist that she is still able to work at her desk job without any challenges. So my question to you is, which of the recommendations listed below would be the most appropriate in Mrs. NTP's case? Should she apply clobetasol 0.05% ointment to her hands and feet and discontinue the sorafenib permanently, or would you recommend using emollients, avoidance of hot water, and wearing of thick gloves and socks to retain moisture while continuing the sorafenib at the current dose with close monitoring? Or would you recommend using emollients, avoidance of hot water, and the wearing of thick gloves and socks to retain moisture, but decrease the sorafenib dose to 400 milligrams orally once a day? Or would you recommend using of emollients, avoidance of hot water, and wearing of thick gloves and socks to retain moisture, and holding the sorafenib, and then resuming at a dose of 400 milligrams every other day once the symptoms resolve? I'll give you 10 seconds to choose the correct answer. So B would be our best bet. Remember, hand, foot, skin reaction, what we abbreviate as HFSR, and rash are the most common side effects of sorafenib, and they typically occur during the first 6 weeks of treatment, but they may occur as early as the first to second week after starting treatment. Now, according to the common terminology criteria for adverse events, what we abbreviate as CTCAE, dermatological toxicity is graded as follows. Grade 1 entails numbness, dysesthesia, paresthesia, tingling, painless swelling, erythema or discomfort of the hands or the feet, which doesn't disrupt a patient's normal activities of daily living. Grade 2 involves painful erythema and swelling of the hands and feet, or discomfort affecting the patient's normal activities. And grade 3 involves moist desquamation, ulceration, blistering, or even severe pain of the hands and feet, or severe discomfort that causes the patient to be unable to work or perform activities of daily living. Now, based on this criteria, Madam NTP has grade 1 HSFR, for which the package insert recommends it to continue treatment and to consider topical therapy for symptomatic relief. The application of that clobetasol cream. Now, all the other answers are more appropriate for patients with higher grade dermatologic toxicities. Now, just like to add that patients treated with sorafenib should be monitored for HSFR and even rashes, which generally occur, as I said earlier, within the first 6 months of treatment. Now, the package insert provides recommendations for the management based on the grade of dermatologic toxicity. So I would recommend you read carefully. Now, for patients with the HSFR, they should be instructed to stay proactive in keeping both their hands and their feet moisturized with thick urea-based cream. They should avoid hot water, and they can also remove thick calluses, and they should also be encouraged to wear comfortable shoes so that there are no pressure marks formed. Now the goal is to maintain the sorafenib dose for as long as possible. So my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to urge you to give it a thumbs up, to like it, and to leave your comments, and to share it widely with your peers. And if you haven't yet done so, I would humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you all very much for viewing and for listening to this video. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to interacting with you in the next video. Thank you.